Hope you are doing well. I
Yes,
think we
thank you
should
very much.
start. I will just take 5, 8 more minutes in the introductions and thing, and then so that we can finish on time anyway. So I think if you can just kick start now. So
Okay, sure. So, Assalamu alaikum. My name is Kiran Amir, and I am the Director of Operations at PARSA ECHO Pakistan Super Hub. Please bear with us today as we have shifted to the new iEcho platform for the first time, and things are different. We will be learning as we go along. Welcome to the Echo session in Liver Palliative Care Echo Series, Batch 2. It's in collaboration with Pakistan Kidney and Liver Institute and Research Center and Pakistan Society of Hepatology. We are also thankful to Ferosens Laboratories Private Limited for their unrestricted educational grant. Our expert today is Professor Max Watson. The topic today is Introduction to Palliative Care in Liver Disease. Before I introduce you to our expert for tonight's session, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA, intending to disseminate knowledge and best practices. PARSA ECHO Pakistan started as a hub in 2017 and became the first super hub in Pakistan in 2021. We are following the guidelines of Project ECHO with an objective that community providers learn through video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patient otherwise referred out. Patient with chronic condition get high quality care without travel and waiting. We protect patient privacy, so none of the information used here will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation. So you can unmute yourself for question or use the raised hand option or chat box. By participating, you have given the consent for recording. The recorded session will be available on request. For CME credits, please get in touch with Uzair. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 24 hours. You are requested to fill it out as soon as possible to avail the opportunity of CMEs. For the convenience of participant, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. Our expert for today's session is Professor Max Watson. He is a palliative care consultant in Northern Ireland. In addition to working in hospice in London and Belfast, he also holds an honorary palliative medicine chair at St. John's Medical School in Bangalore. Influenced by his experience of working in rural Nepal for 8 years, Professor Max has developed a range of educational programs and handbooks, including the Oxford Handbook of Palliative Care and the European Certificate in Essential Palliative Care. As the director of Project ECHO with Hospice UK, Professor Max is leading the spread of ECHO methodology across the UK with more than 60 networks. I will now hand over to Dr. Amara, consultant hepatologist at PKLI Research Center, who will further introduce the palliative care project and participants' introduction. Dr. Iram, a consultant in internal medicine and palliative medicine at Shaukat Khanam Hospital, Lahore, is our co-facilitator for today's session. Has Dr. Amara joined yet?
no, thank you, Kiran. I'll take it from here. Amara just got stuck in fog. I just got a message, and so she'll be with us, I think, in 10 minutes. So thank you very much, Max. Kiran was saying session will be bilingual. So I hope you are able to understand some Urdu and Hindi anyway by virtue of being to the places. And I won't be surprised at all about your skills here. But just Max, just to give you a background how we started. We had one session with you, and we are really looking forward to introduce the full course in Pakistan as you very kindly shared the details with us. But this was started by PKLI, Dr. Farooq Khan, Dr. Iram, Professor Altaf Alam, because uh, our background being a gastroenterology in hepatology, we see a lot of patients with decompensated liver disease who cannot afford transplant, and people who are suffering from hepatocellular carcinoma. Unfortunately, you must be aware about the situation of hepatitis in Pakistan, which is not settling down. the decompensation and liver cancer has exploded in a way. So all these patients who cannot be helped with transplant or they cannot afford treatment, that's another reason. The thing that we feel is they are not properly counseled. And the other thing is they keep spending money in hope of cure, and they virtually sell their houses, their livestock, and everything. So that's where we really need. And most of the spokes that we have encouraged to join are from the peripheries because these are the areas where they have limited access to the tertiary care center and they are being referred again and again. It puts a lot of strain on the resources of at the tertiary care centers, and sometimes they are overwhelmed by these patients who come there with some hope, some false hopes, and we want actually that they'll be taken care. One of the objectives is for the like center like PKLI, which is the liver transplant center, Shaukat Khanum, where Dr. Iram is, where they receive all patients. They can only cater for the patients who can be offered some help. But most of the stage 3, stage 4 cancers who need palliation, they go back in the community and where in every city, we should have a name. We can tell them you go to Dr. XYZ and they will take care of your needs. So that's a little background. That's we have made a humble beginning. We did one batch without you. Not this batch. We were truly honored to have you with us for guidance. So once again, thank you very much to give this inaugural talk for help people uh, learn something about palliative care and when we take it further along. So Max, it's over to you. Thank you very much.
Assalamu alaikum. Thank you so much for your kindness and the opportunity to visit again, albeit virtually, Pakistan. I was there a few years ago and in Lahore and in Karachi, and I was so touched by the kindness and compassion of people. A quieter country than India, where I'm a little bit more used to. Thank you. I wanted to share a little bit about palliative care in its totality, and in particular, just focusing then a little bit on the particular needs of patients who are dying from liver disease, hepatitis, or liver cancer. So I hope you can see the slides okay. So I'm not being paid for today's talk. I'm not sponsored by any drug firms or anything. I guess my vision is that the care that we would want for our own families would be the care that would be available for all patients across Pakistan. So I wanted to give a little bit of background, personal and other background, and then think a little bit about the why and the who and the how and the what and the when of palliative care and how it might apply to us in our roles as gastroenterologists and our roles of looking after people who have very little chance of cure, even if there was access to liver transplant, there isn't the resource or other issues. So how do we manage that, and how do we build a culture where palliative care is recognized as an important part of what we do? So a long time ago, I had some hair, as you can see, working in an outpatient clinic in Nepal, in Tansen, in rural Nepal. And we saw so many patients who were traveling all over Nepal and North India, and even from Pakistan, looking for cures, for treatments for which there were no cure, spending money, as Dr. Assad said, selling their fields, giving away resources which they didn't have for cures that were not going to help them. And indeed, in their search for cures, were often ending up dying far away from their homes, on trains and in places where there was no peace and no opportunity to die well. And so our question, I think, as we think about end-of-life care, is our end-of-life care good enough for our own family? That's our kind of standard. And if it's not good enough for our own family, how do we make the care for this patient better? Across the world, we know that the world mortality rate has remained at 100%. Even in 2023, we all will die. That's the nature of it. So if we're all going to die, how do we make sure that the one thing that we will all do together, we can do that as well as possible? And I think the issues that apply to us is that very large numbers, very large percentage of our patients with liver disease are palliative from the moment they arrive at our hospital. And even before that, many of the patients we're phoned about, we can tell from the phone conversations and the blood results that are shared that these patients also are palliative. And yet, maybe they're going to get on a train or they're going to travel hundreds of miles in pursuit of what we know is not going to be of help to them. If we look across the world, we see that the issues that we are facing in gastroenterology in Pakistan are being faced in many countries where now death and dying has really become a medical event. And yet death and dying is a life event rather than a medical one. We've done a lot of research in villages in Nepal, and I think there's some overlap between what you would find in villages in rural parts of Pakistan and villages in Nepal in relation to how villages cope with death and dying. We did interviews with a lot of families, and this is an example of one particular story. And as we looked at these stories from villagers who were talking about family members dying, what became clear was no one had prepared them for the fact that their loved one was dying. It was hard to acknowledge dying in the village. There hadn't been preparation for what dying might be like for the family. And so if somebody became breathless, there would be an urgent need to go and get oxygen or to rush them to the hospital. And dying often in the village turned into a crisis with ambulances and oxygen and the last hours of life spent in a panic without any opportunity to peacefully say goodbye to your families. There was also a lot of fear in the village of what the neighbors might think. Oh, they didn't want to spend any money on him. Oh, they don't care what an awful family they are. And then there was the costs of these emergency treatments, which are futile, but also the cost in terms of face and being perceived as an uncaring, poor Muslim family by not being seen to try or to care. And then there were the issues about decision-making, and there would only be one really major decision maker in the family, and people would always go by what he said, even if it wasn't what the patient wanted. These were the kind of issues that were coming up in our villages in Nepal, and I wonder, are they similar sorts of issues in villages in Pakistan? If we look across the world at what people want around the time of dying, it's universal, whether it's in Manchester or in Lahore. We want somebody we can trust, in the same way as somebody who's about to give birth really values a midwife who's been through that process. Having someone who can guide us in this once in a lifetime event is really valuable. Many of us want our close family close beside us. Some small percentage prefer to die alone. But the vast majority, they want the family around them. They want their symptoms to be controlled. They don't want to die in pain. And ideally, they want to be in their own home or in a safe, familiar place with the opportunity to plan, to make arrangements for your daughter to be married, to make arrangements for how your land is going to be divided up, to make those plans which are for after you have died. But so few of us have the opportunities for these things, even though universally we want them. So we want good treatment and in the midst of a compassionate community. So in gastroenterology, I liken so much of what we do in palliative care, it's like riding two horses, and we need to ride often them both together. One horse is the horse of cure, where we're treating the reversible, we're giving the antibiotics, we're giving the support medications which can help prolong life. But at the same time, we're also riding the horse of care and recognizing that life is coming to an end and that we have to keep people comfortable and well supported, comfortable physically, emotionally, and financially in every way that we can. And often we have to ride these two horses together. And that can be challenging for us. And sometimes we ignore the care and we just focus on all the curing things, and family get the belief that, you know, cure is about to happen. And then they get very disappointed and sometimes very angry when their relative dies, because no one has prepared them for the fact that this is a terminal condition and it's very unlikely that they are going to get cured. So we need to learn how to ride the two horses together. Palliative care has got a bad press across the world. Some people link it to euthanasia and other strange things from the West. But palliative care has now very strongly opposed to euthanasia. Palliative care also has been seen to have really positive life-prolonging impacts, because if you control people's symptoms well, often people can live longer than those who are undergoing very severe and difficult treatments. This was one study looking at lung cancer, which showed an increase in mortality by the introduction of palliative care early on. Another study done much more recently showing the same thing. At its heart, palliative care, modern palliative care, owes much to a lady called Dame Cicely Saunders from London. I had the chance of working with her, and this is a quote from her: "You matter because you are you, and you matter to the end of your life, and we will do all that we can, not only to help you to die peacefully, but also to live well until you die." So this was, yeah, a long time ago when I had the chance of working with her. But the real root of palliative care does not lie in London or in the UK or in the West. It lies in the heart of compassion, and that heart is in Pakistan, as it is in other countries. As the Hadith shows, none of you believes until he loves for his brother what he loves for himself. At the very heart of Islamic thought and compassion is palliative care. In India, I was struck. We went to see this lady with spinal cord compression in the village, living on her own in a very small little hut. In the UK, it wouldn't be possible for somebody with spinal cord compression to live on their own in a hut, because, oh dear, we get so worried. We'd have to have them in a special place. But here she was living in her own place on her own. How did this happen? Because very soon we saw this boy from the nearby village coming with her breakfast. Sister was going to come shortly after to help with her washing. Mother was going to come with, in other words, the village was looking after her, compassion rich. Didn't have much medicine, but they had a lot of compassion often in the UK, we've got a lot of medicine, but maybe we lack some of the compassion. So how are our patients dying at present? I'm going to give you some options. Maybe you can recognize some of them. Option 1, in the hospital, patients who are dying, transferred to a side room, screened out. We don't talk about them. Senior medical staff withdraws after a brief interaction with the family. Junior staff manage the situation. Routine nursing interventions continue, blood pressure, pulse, routine bloods. Resuscitation attempts are done because it's easier to do the resuscitation than it is to have the conversation with the family. A situation which is treatment rich, but compassion constrained. Option 1. I wondered, you recognize that at all? Option 2, home-based death, not always by choice. Decreased access to working healthcare systems, financial, personal, logistic constraints, lack of pain and symptom control, but access to family and compassionate community. What is not communicated is finally understood, even if never spoken in this situation. Compassion rich, but treatment poor. Option 2. And then perhaps the loneliest option of all, the wealthy option, the impersonal option, the mechanical, moved to an ICU, ventilated, bewildering, costly, frightening. We've got to keep them going. And thousands and thousands and thousands of dollars or rupees spent, and a lonely, isolated death. Is end-of-life care good enough for our own family? And yet, the reasons behind this are because people feel that this is the most loving way, and they don't have a concept of what good palliative end-of-life care could look like. And if you don't look for palliative care need in your liver patients, you won't see it. All you'll see is their need for antiviral drugs or their need for drugs to help replace their lost proteins, and they just become a medical problem. But there is much more to human life than just treating a medical problem. Dame Cicely discovered ancient truths which had been highlighted by so many across our world before her. Her concept of total pain, that we experience pain not just physically, but psychologically and socially and spiritually and financially. And all these pains interact with each other. And some of the patients that we have most difficulty in managing their pain is because they've got really deep-seated issues within their family. They've got lots of fear. They've got financial worries. They've got lots of other things going on in their lives which don't respond to analgesics. So managing suffering extends beyond just giving pain-killing medicines. Physical, social, psychological, spiritual, all contribute to the suffering of your liver patients. Social pain is very prevalent in Pakistan. The disruption and the disorder and the concern and the fear that people have. This was from an asylum seeker from Pakistan. I had a strange pain. It started in the whole of my body, sometime here in the breast, sometime in my body. It was circulating like blood. Not a physical sort of pain that you could understand, but nonetheless a pain which was very real for her. I grew up in Northern Ireland. This is a picture just outside the office where my father worked in Belfast. And the pain of being in a war situation or a violent situation had an impact, not just on the people caught up in that, but also on whole of society and how society responds and deals with pain. And yet the treatment is not to put morphine into the water supply. It's how do we help each other as we respond to such societal issues. So total pain needs both really good treatment, but it also needs true compassion. So palliative medicine isn't, it is for any age, pediatrics to geriatrics. It should take place whether you're a surgeon or an anesthetist or a gastroenterologist. It should take place irrespective of what organ you're looking after, whether it's the heart or the liver or the lungs. And it should take place in any location, be intensive care, emergency room, in the village or in the city, any village, any illness, any age, any location. And we recognize palliative care trajectories or dying trajectories, the classical cancer trajectory of your patients with liver disease entering the last year of life with quite good functional status, and then the treatment stops working and the patient deteriorates and dies quite finitely. The organ system failure trajectory, the patients who have got persisting liver failure, slowly deteriorating, and they enter the last year of life, their function is already compromised. And then they get an infection and they come in and they deteriorate and they're treated and they come back again. And then a few months later, there's another problem. They have a bleed and they come in again and they're treated and they come. But so rarely do people have the conversation at this time that this is likely that these are the last months of your life. And so when they come in the next time and they don't recover, then family again could be very upset that you must have made a mistake, because all the other times we've come in, you've cured. So what's gone wrong? Different trajectories, which we can recognize as we look after our liver patients. Any location, compassionate, good, holistic treatment, whether you're in the village or in the ICU. Well, what do we offer with our palliative medicine? We offer good symptom control, really important for your liver patients with their itch and their nausea and their constipation and their delirium and their psychological and their fluid overload, managing those symptoms to help people be as comfortable as possible. Good communication, absolutely crucial, so that people can make plans which are appropriate for where they're at, perhaps the most challenging of all the aspects of palliative care. And good quality disease management, because expert liver management has a huge palliative care impact. If you're managing that liver disease well, then the symptom burden is going to be less. And obviously, then as we move into end of life care, the importance of good communication and managing those symptoms associated with the last days and weeks of life, and helping thus a family to cope well with bereavement. Because how a person dies will have a huge impact on how that family copes with that death moving forward. Across the world, 56 million people die every year, 44 million of these in resource-reduced countries. 60% would benefit from palliative care, but how many actually receive such care and the opportunity to prepare for their dying? The WHO encourages palliative care development in each country, and they say to develop palliative care services, you need government policy, you need good education, and you need drug availability, and then you need commitment champions, people like yourselves who are committed to bringing palliative care into liver care for your patients. What about drug availability? A real issue in Pakistan. This is a paper in 2021. I understand that pharmacotherapies for pain management, for example, are quite limited in Pakistan to tramadol and injectable tapentolol, buprenorphine sublingual, nalbuphine injectable, and adjuvant analgesics like non-steroidals. Morphine is not readily available, and other strong opioids are more difficult. And this is how it was for us initially in Nepal when I worked there. The only opioid that we had, oral opioid that we had for patients, was in cough codeine linctus in cough mixture. Through strong advocacy work, we now have morphine available across Nepal. I hope that will happen in Pakistan. If we look at a map of drug availability, of opioid use, we see in America and Europe overuse of opioids. We see in Asia marked underuse. So there's an imbalance, and where there's lack of use for pain, we know that often there is pain associated with dying. The mean consumption of morphine in the Eastern Mediterranean region was 0.384 milligrams per capita. The global mean is 6.2 milligrams per capita. In Pakistan, in 2014, it was only 0.05 milligrams per capita. And it's estimated that only 2% of terminally ill patients have access to opioids for pain management. And at the same time, Pakistan is in the top 10 of countries with opioid addiction problems. So this makes it really complex to be able to access the treatments which could help with the pain of your patients. Education, another, how do we educate and who do we educate? I think supporting society to recognize that the management of pain and the recognition of death and dying is acceptable. We did work as I worked with the Aga Khan Foundation in establishing palliative care in their hospitals. And we worked with an imam to ensure the theological background and basis for palliative care was totally in line with the teaching from the Quran. Having that support from religious leaders and the health ministry, really important. Educating patients and other professionals and doctors and nurses and modeling those crucial conversations, really, really important. In terms of my own education in palliative care, it is the patients who teach me most, listening to their experience and what is really important to them. To build on the good, on the compassion that's there, on the family relationships there, on all the positives that are there within our culture, to build on the existing traditions and cultures and supports that exist for the dying, really important. To use stories and connection so that people can identify that the road to death and dying can be a comfortable one. To develop practical ways for managing the particular issues that surround and challenges of dying with liver failure. to model that good care and to set yourself and your team that standard of care. Would the care that we offer be the care that will be good enough for ourselves or our own family? What about national education? I think having some form of direct palliative care education program that Dr. Assad was talking about can be really helpful if it's accredited, if it's locally appropriated, if it's Pakistanized to be appropriate for the medications and the culture and the approach, and it's got recognition, and it involves not just doctors, but also the whole healthcare team who are required. We had a certificate program in the UK that we created, and we Indianized it, and we've Nepalized it, and we've Kazakhstanized it to make it appropriate for countries. But what has taught me most, and what I suspect will be your greatest teacher, is when things do not go well. And it's our successes teach us very little, but our failures teach us most. And it's the patients who did not die well. When we reflect on them, that's our gold in terms of learning and understanding and determining that we will do better the next time. So finally, when will we introduce palliative care? And we already are. If we have eyes to see in our liver patients, we will identify palliative care needs often alongside treatment needs. And riding those two horses is often the way for the majority of our patients that we see. When we do a referral back to the village, back to the local doctor, every referral is an educational opportunity, an opportunity to share with your colleague in the rural setting, both respect, but also the opportunity to encourage palliative care thinking. Create your allies, just as Dr. Assad was saying, your allies who are on board with you, who you can refer to with confidence. Develop the research questions to demonstrate the quality and the importance of what you're doing and how families so value the palliative care approach. And develop not the London way or the Indian way or the Nepali way. Develop the Pakistani way, going back to the very roots of your compassionate culture, the way to help the dying. The last time I was in Lahore was in 2013. And at that time, on May the 19th, Samina Kayal Baig became the first Pakistani woman to climb Mount Everest. Who would have thought 20 years previously that a Pakistani woman would climb Mount Everest? She led the world, achieving a really difficult thing, and we can achieve palliative care for our liver care patients across Pakistan. Thank you very much indeed. Thank you.
Thank you. Thank you very much, Max. Very inspiring, and I think it will just set the right tone for our program. Dr. Iram, over to you, and then we'll be open for any questions. We still have 20 minutes.
Thank you very much, Max. I think what you have said has already touched my heart a few years back when I was the one who started my fellowship as an internal program here in one of the hospitals who were offering internal program of fellowship at that time, a few years back. And to be honest, I think, like you have mentioned, it is so important to educate doctors around of how important this palliative care is and how we can really help our patients from all aspects. It's not just giving them the medical aspect and then telling them to please go home and do the best what you can do, because people cannot rest at home when they have somebody who is in pain, and especially a child. It's very difficult for adults, but it's much more difficult for a child who really needs palliative care, and there is no such concept. So I think the whole purpose of this course is really to educate our doctors who are able to work around in surroundings and can spread the message. They can help to be our force really to, spread the what palliative care is, and to learn how they can start practicing at their level, because it is it's a I would say it's a multi-dimensional approach that is needed rather than one single medical approach. um, I think there's a general concept that we always keep talking about: low resource country. Pakistan is a low resource country. But on the other hand, I can say that, we are very blessed from something else as a background, or as another point. The family system, the strong cultural values people, portray here. It will be much more easier for us to teach our patients and their families to look after at home, rather than, if we don't have social services, we can still manage a lot. All this needs is, to go through a platform where doctors who are able to teach others and can train them. So I'm really grateful for your thoughtful words, and, for all the participants. I think the discussion is open because we've got limited time now. And we would like, I'll invite everybody to open up and speak and bring up with your ideas.
Thank you very much. Thank you.
Okay, Max, I have a question. Going by your experience in Nepal and India, what do you think was the biggest challenge in terms of setting up a palliative care or sensitizing people?
There were several big challenges, and it's not as if we've overcome those challenges, but I think you'll excuse me for saying this, I think the biggest challenge was the residue left by the British Raj in terms of opioid legislation, and that impact, which made the availability of opioids to manage pain so difficult, had a profound effect on ensuring that millions of people across South Asia have died in unnecessary pain from medication that was very cheap and was actually growing in South Asia. So the legislative hangover from the Raj, I think, was huge. I think the second biggest thing was communication skills training, and doctors being trained always in a fix-it model in medical schools, that all we do is fix things. So they have an acute medicine model. They have no concept of kind of managing people who are dying. It's all take this and get better, take this and get better. And as a result of that, there was a breakdown in trust between patients and doctors. And with that breakdown in trust, then we found many families would go to the quacks or the village healers, and as a result of that, they would spend so much money on treatments which wouldn't help them, because it was easier for a doctor to prescribe vitamins or paracetamol than it was to take the time to have a conversation. And because they hadn't seen their seniors and their bosses taking the time to have the conversation, that was the model that they have in managing patients. So those are the two things which I think really have undermined the development of palliative care in India and Nepal.
Thank you. Amara, you have a raised hand. Please go ahead.
Yeah, thank you, Dr. Watson. That was an amazing presentation. I think you hit kind of all the notes. My question for you is like, in Nepal, what was the experience? Some of the things that I struggle with mostly is kind of trying to have that conversation with the patient. I read your presentation on, or the booklet on good death, and I think that's very powerful. But I think the patient has to decide what death really means for them, and I think in a cultural setting like Pakistan, they don't let you tell the patient. And I'm wondering, like, Nepal being a Muslim country as well, like, did you have a similar experience there? And like, from your research, what does the patient really want? Does the patient want to talk about it? Because, a lot of times when I ask the patients what they want, some will tell you, let my family make the decision. Some will openly say, I want to make the decision. But is there a guiding principle, for a country like Pakistan, like that we can, have?
Nepal is mainly Hindu, but the issues are very much the same. And when you read the literature from the West, it's all based on a very autonomous approach to individual rights and the individual making their own choice, which is not true of the culture of the society where many within Pakistan or within other parts of Asia, they go along with family decision making. They go along with, we did a study with such, and we asked mothers about, grandmothers about end of life care decisions. And they said, why are you asking us about this? We've never had a decision to make in our whole lives before. And suddenly you're asking me, where do we want to die? That this hasn't been part of our lives. And so there's an arrogance sometimes in the West to impose individualism on countries where the culture is of collective family decision making. But Pakistan isn't unified. You have many Pakistan families who are living in America and Australia and the UK who have imbibed of the culture of individualism, and so you've got across the country a bit of sometimes a struggle between different approaches. Some very content with the traditional, I'm content with what the family will decide for me. They will decide who will be my husband, they will decide who will be my bride, they will decide how I will die. And I am content, and my worldview allows me to be content with that. And so I think we've got to be humble in recognizing the different ways in which people make their choices. But we should still, even within those frameworks, help them to make as good a choice as possible for them. And that's really difficult when the family say, you mustn't tell mommy, you mustn't tell mommy. Okay, we're not telling mommy, but what do you think mommy would want? And what would help mommy? And what would be the best thing for her? Does that make sense at all?
Yeah, no, absolutely. And you answered that point where I was trained in the West, and I think that I do take a Western concept where I say, the patient has the right to make the decision, but you make it very easy for me where, if somebody has never made a decision, you don't want them to make that decision themselves as well. So that makes complete sense.
It's not fair. It's not fair.
Yeah.
It's not how they understand themselves, how they understand their life, how they understand their relationship with the world.
Yeah. Yeah. Makes perfect sense.
You won't get this chance a lot.
Dr. Assad, can I maybe turn the question to you? What do you think are the main barriers to developing palliative care services for patients with liver disease in Pakistan?
I think a part of it has been answered by you. Uh, we are in a fix-it model, to be very honest with you. We are talking about problems and solutions and treatments, and this faith in Almighty, the miracles will happen. We are all talking about a good life. No one dares talk about a good death. So I've gone through the literature that you sent, and it's really amazing. And even today, I had two families, and I'd spent about 15 minutes with them, and the whole family very aggressive to start with. The guy had hepatitis B, doing well, and suddenly a 140 millimeter tumor pops up from somewhere with alpha fetoprotein of 7,000, ECOG 0, otherwise fit, and family cannot accept it. It's invaded into the portal vein. Bilirubin is now 4. I know, we don't have much in term, but he's like 55, and family, but then I calmed them down, and then I got the whole family. There were, I think, 3 daughters, 1 son-in-law, 1 son, 1 wife, all these services, bring them all. And then I started with this good death concept, and without going into too much detail, but where we are and where we stand. And it has started to listen to me. Is a reasonable, I would say, we're reasonably educated family, a business family, a reasonable educated family. Uh, uh, but but this thing sometimes, the belief in miracles. Oh, you said that God can do anything, So it's sometimes it becomes very challenging to tell them. The other thing, as Dr. Amara pointed out, is about the family things, because it's always a struggle whom to break the bad news. Usually, talking directly to the patient in question, it becomes very, very challenging, and the family is annoyed, and sometimes it just breaks the whole fabric down. I mean, the whole communication dies down. If they get annoyed, I mean, of course, that you told this to my father, and this happened, and this happened, and this is this. Um, so this is something that initially that I'm feeling to just bring them there and talking about a good death. um, you know like a patient, today it happened, metastatic CA prostate, dying in a village, and the whole concern was securing an IV line when they have punctured every known vein in the body. I said, why do you want to give fluid to him? So just to bringing them to the thing I came up with, you get a dropper, get a juice, and just drop a drop of juice in the mouth, and keep his lips wet and tongue wet, using a forceps. Don't stick your finger in, and just to give them something. I'm just trying to find, maybe Dr. Iram can answer. We have this subcutaneous infusions things available a lot, but then you bring, and after 15 minutes, I think 10 or 15 minutes of discussion, they understood my point that subcutaneous injections could be used for pain control. And so it's about spending time on a good death concept. That's what I would like to say.
Can I add one thing? I don't know if others have the same experience. So I feel like we're a very emotional nation as well. And talking about, and we don't want to accept death. Like, we all believe in the life hereafter, I feel. But I think when it comes to, like, dying, we become emotional, and we don't want to die. And I think we want to hold on to this world. Maybe, I don't know. I'm going to say this from my experience. I might be wrong, but I feel like, it takes a lot of time to counsel patients that, the end is coming. And I think The other thing that we don't have is, we don't have time for our patients. And I think everybody, is in this quick fix, and people don't spend that extra time. And I think when you do, your patients do get it, and they do move towards a different track, and they do want to choose a good death. But I think it's, trying to work with those emotions and those family dynamics and getting them on the right path, that's just time consuming. And unfortunately, I think we're not trained to handle those conversations well.
I would like to add here, because whenever this happens, and the primary treating physician has not told them about what the real picture is, and the family's expectations are sky high, they come to see one of the, maybe a palliative physician, if at all they find. And the expectations, when the palliative physician starts telling them about, the irreversibility of the whole disease pattern, and how things are gonna, we need to learn to live with what we have until how long we have. When you start such discussions, they get, rebuked by the palliative care physician, really, because he said, I was never told this by my own doctor. I was never told this by my own physician. So probably you don't know how to treat it. And then it takes them so long to actually realize. And then they come back by asking that, we really need help, and if you can help us with the symptom control and other things. So I think what it really needs is time is required for such discussions. Time is really required, depending on the patient's age and the patient's situation, or the patient's value in the family. If it's one of the owners of the family, or I would say a head of the family, I think the time for discussion will be different. If it will be one of the children, the time for discussion will be absolutely different, because you will need to get everybody on the same page. If it is one of the elderly lady and the family is half counseled, it won't take that long. All they would need is to understand what's actually happening and how much they are left with. So I think spending time with the patients is really something that's important. And that's the point when you ask them, what do you want at the moment? Just like Dr. Asad has mentioned about today's case about IV lines, if somebody might have even tried to ask the patient, do you think we shall try once? And I assume the answer would be, please stop. And let me live. Please stop this. That happened to one of my patients who I took over yesterday under a palliative care. And once I started discussion, and I asked the patient what your wishes are, do you want to be pricked again and again for something you have already had a external jugular line that was dislodged? And I told them that, the next thing is the central line for one dose of antibiotic, which hasn't helped at all over the last 10 days. Do you still want that? And the answer was very clear from the patient, please let me live with whatever I am left with. And that was sufficient enough for the family to counsel them at the same time, because it's coming from the patient, it's their loved one, and they do respect their wishes. It's just about, bringing the honesty on the page, I would say, because half of the times it's like the family is hiding. Whosoever comes with the family takes the lead and takes everything, absorbs everything in themselves. They do not share that with family. They do not update them, other family members, and even the patient, how advanced the disease is. That is a very difficult situation when you have to actually bring down both of the patient and the family together on the same page realistically, by letting them know that, he's your father, he knows much more than you think he knows, and you are his son. Your facial expressions are telling him everything. There's just a barrier of communication between you both, and you're living in the same home, like hiding from each other, because you think that he doesn't know and he think that I don't know. And the level of anxiety that brings leads to another, the whole set of symptoms that cannot be resolved by simple pain management things. So like Dr. Watson told us about the whole concept of total pain and the involvement of spiritual, psychological, physical, and all other needs. I think it's important for us to learn how to embed all that in our daily practice as well. So,
Can I just
Thank you.
mention just a couple of things in response that I think other countries have found helpful. One is good celebrity death. If there's somebody who is well known in Pakistan who dies a good palliative care death. If you can get in your soap operas on television an example of palliative care and why a family chose palliative care as opposed to going forward with treatment, so that people develop some sort of concept of what dying is. The second thing, if it's possible to produce a leaflet about hepatitis care, talking about the different sorts of treatment options, but also including in that leaflet the need for palliative care as well, and what palliative care is, and when we would start that, and so that people see the spectrum of care right from the beginning. This isn't something which is because treatment has failed. It's something that we know can happen to a significant proportion of our patients. And if that's kind of made clear at the beginning, it makes it so much easier to be able to refer to that as we talked about at the beginning. And yeah, yes. So those are a couple of celebrity dying well, giving a model, literature for a literate family to give them that understanding. Yeah, I think that can help. And the final thing, and perhaps the most important, is the teaching other doctors, your cardiologists, your oncologists, your respiratory physicians, that in India we've started now with joint palliative respiratory clinics, joint palliative cardiology clinics, so that it's seen as not a sudden move to death and dying, but it's actually part of ongoing care. And it's just, yeah. Sorry, I've taken you beyond your time. I hope you will sleep well tonight and are not going to be thinking too much about palliative care. Thank you.
Thank you. Rarely we realize that 60 minutes may not be enough. Professor Altaf is our course director, Max. Just like to have a few words from him before we wind up.
Thank you.
Thank you very much. Thank you, Max, for a wonderful, thought-provoking talk, and very inspiring as well. I always say that we have been trained to practice the science of medicine, but not the art of medicine. And anywhere in the world where I have been, young, enthusiastic doctors, when you give a case scenario, they will immediately jump to treatment. They would never say, talk to the patient, explain the natural history of the disease, talk about the outcomes of treatment. So they jump to medicines and the treatment part first. And, that's true for everywhere in the world, because we as undergraduates and postgraduates are not really inculcating this art of medicine into our lot. So a very good start to our program. Some very good people here, Dr. Amara, Dr. Farooq, Dr. Asad, Dr. Iram. They have started this course. It's a beginning for our colleagues, for our doctors. We are learning ourselves. The colleagues are the junior doctors, the junior consultants are learning from this course. And I hope this doesn't end here. We make formal national medical guidelines and make it a compulsory subject at both undergraduate and postgraduate level, so that the future of our medical fraternity is helped by this very important aspect. Thank you very much, Max. Thoroughly enjoyed your talk. And over to Asad. I think we are running late, so over to us.
Thank you. Kiran, over to you for some announcements, and then we can call up the session.
Okay, sure. Thank you, Max. These are weekly sessions. So next session will be on Tuesday at 10 p.m. on easing suffering in liver disease, focus on pain and agitation. If you want to join our other series, please contact Uzair, our coordinator. And we are grateful and thankful once again to Pakistan Society of Hepatology, PKLI, our team at PARSA Trust, PARSA ECHO Pakistan, along with Frozen's Laboratories for the unrestricted educational grant. So Allah Hafiz, goodbye. Uzair, thank you.
Thank you, everyone.